Good evening. We're now going to discuss a subject which is of common interest to both the primary care practitioners as well as the secondary care. And there is not much controversy in the way of treatment or way of investigations or overall management. So we're going to talk about celiac disease and the guidelines from NICE and also from relevant local organizations. Celiac disease is a common condition, but it is unfortunately not properly picked up at its beginning. And quite often there is delayed diagnosis and haphazard management in the primary care, full stop. So we'll have a look at these aspects critically. And for this to happen, I'll now be wanting to share my prepared slides. So we now go into the presentation called celiac disease. First of all, let us describe and define celiac disease. It's a chronic autoimmune, immune-mediated systemic disorder showing itself up in the gastrointestinal tract, but elsewhere as well, occurring in those genetically predisposed people who have carried the appropriate genes, but it is triggered by exposure to the body of dietary gluten, which is a major complex protein component of wheat, barley, and rye. The condition is characterized by an inflammatory small bowel enteropathy with a variable degree of intensity. So it produces a vast range of gastrointestinal and systemic symptoms, and in addition evokes the presence and identification of numerous celiac-specific autoantibodies. Although it is an ancient disease, it had in the past been known as celiac sprue, gluten enteropathy, or non-tropical sprue. Celiac disease is basically triggered by gluten, and the active principle of gluten is gliadin, and commonly it's present in wheat, barley, and rye, grains, seeds, products, and in a small quantity. Gluten as part of food is found usually in pastas, cakes, cereals, most types of bread, certain types of sauces, some ready meals as well. Remembering that most beers are malted varieties made from barley. So there's a large range of food products which contain gluten. And even in a small quantity, gluten is capable of triggering a response, which ranges from an IgE, almost immediate response, to a slow response which goes on for a long while, producing numerous symptoms. So there are certain types of celiac disease. The one which is identified on the basis of symptoms, signs, laboratory investigations, and possibly histologically diagnosed as well from specimens obtained in endoscopies. But there are some other kinds of conditions mimicking celiac disease, but they have different attributes. And the potential celiac disease is an asymptomatic or symptomatic condition with antibody positivity for celiac disease, but there is no villus atrophy on duodenal biopsy. So there are markers present with or without symptoms, but there is no histological diagnosis of celiac disease. So these are potential celiac disease conditions. Then there are non-responsive celiac disease as well, which means that the symptoms are persistent and there is enteropathy, but there is no improvement with symptoms or enteropathy on self-reported gluten-free diet. And this might also mean that strict compliance of gluten avoidance has not been made. Then there is refractory celiac disease, when there are persistent symptoms and the duodenal biopsy suggests villus atrophy, despite strict adherence to gluten avoidance. Without exposure to gluten, it is unlikely that symptoms will develop. But sometimes, in rare cases, there is histological evidence in an asymptomatic state. Now, how often do we deal with celiac disease? And research tells us that it occurs at any age, usually in young people, of course, and even in childhood, and in any ethnicity with no gender preference. Although in some studies, female preponderance is reported. In effect, observational studies suggest that celiac disease is underdiagnosed. That means many people suffer from celiac disease, but are neither treated nor investigated, and therefore they live with mild form of symptomatology for a very long time until the diagnosis comes to light. And in the same way, the general observational assessment suggests, by estimation, that for every one person diagnosed with confirmed celiac disease, 7 to 8 people remain undiagnosed. So it is impossible to confirm the incidence, but in general, it is said from a number of studies that both in Europe as well as in the UK, about 1% people suffer from celiac disease. However, of this number, only 10 to 15% are properly diagnosed. The rest do not have diagnosis made. The celiac disease usually occurs more often in 2 peaks. 6 months, that's the age when weaning is taking place, and from pure milk, sort of a baby is being introduced to other forms of nutrition which contains gluten. So from 6 months to 2 years is the first peak, and in the 20 to 30 year bracket, there is the other peak. But it can occur at any time. Overall, the incidence is rising, even taking into account better diagnostic yield. So what exactly causes the celiac disease and how does it progress? So in celiac disease, the body's immune system, on being challenged with gliadin or gluten, mistakenly identifies it as a threat to the body and attacks these particles. This leads the small bowel villi to be inflamed, overactive at first for a while, and then become underactive, and then become atrophied. And this atrophy eventually produced will interfere with nutrient absorption. And so in the long run, a person would be suffering from various kinds of deficiencies and also gastrointestinal symptoms. There are three ways in which the pathogenesis progresses. Research tells us that celiac disease is associated with human leukocyte antibody DQT, DQ2 or DQ8 haplotypes, which means that in siblings, there is a 20% increased possibility of developing celiac disease. And in the other first degree relatives, there is 10% possibility of increased incidence. The other way celiac disease develops and progresses is thought to be immunological. Now, celiac disease is thought to be an immune-mediated GI tract disorder driven by innate, previously existing, and adaptive immune response to gluten. So there are agents available in the body which attack gluten in an unusual way. And similarly, the exposure of body to gluten in a sensitive person will evoke a certain response. And that would therefore produce immunological activity. Certain immunological conditions such as type 1 diabetes and Hashimoto's disease have an increased risk of developing celiac disease. By far and large, gluten exposure is the major environmental factor. There is no evidence that the duration of breastfeeding, which could be from 0 to 6 months or more, or time of gluten introduction to the diet has any impact in developing features of celiac disease. There is a possibility that different GI tract infections, alteration of gut flora due to infection or antibiotics, drug treatment with alpha interferon, upper GI tract surgery may bring out into the open masked celiac disease. But there are no convincing data available, but it is likely. There is no link between type 2 diabetes and celiac disease. However, the current guidelines suggest that all young patients with type 1 diabetes should be screened for celiac disease. By the way, this symbol underneath in a red circle is the warning sign for gluten sensitivity or wheat sensitivity. So let's now look at various symptoms produced by activated celiac disease. So usually there is severe or occasional diarrhea and bloatedness, sometimes constipation, sometimes steatorrhea and weight loss. And some of these symptoms are fairly similar to the symptoms produced by irritable bowel syndrome. There may be persistent or unexplained nausea or vomiting, retroesternal burning, similar to reflux esophagitis. There could be features of anemia with nutritional deficiencies of iron, vitamin B12, or folic acid. Presumably, if the disorders involve stomach or ileum or jejunum, then these deficiencies, in addition to deficiencies of vitamin D, may emerge. A simple anemia not responding to treatment will lead to suspicion that it might be a disease-related anemia, and the disease being the actual illness. There could be tiredness, prolonged fatigue due to the effects of celiac disease or due to deficiencies. There could be aphthous ulcers. There may be development of or conditions similar to dermatitis or petiformis. And there'd be features of hyposplenism, which means greater vulnerability in respect of infection. There could also be immune disorders such as type 1 diabetes associated, Hashimoto's thyroiditis, autoimmune liver disease, such as primary biliary cholangitis and autoimmune hepatitis, or sclerosing cholangitis. So these, if present, would become worse with celiac disease becoming active. Because of selective IgA, immunoglobulin A deficiency, there could be greater vulnerability. And this is something which is seen in genetic aberrations. So if there's a first degree relative with a celiac disease, the sibling is likely to have a similar condition or celiac disease. Symptoms may also include depression, anxiety, or generalized anxiety disorder. Nutritional problems will lead to development of osteomalacia, osteopenia, osteoporosis, or fragility fracture. They could be associated neuropathy or ataxia. In women, it could produce recurrent miscarriage or subfertility. How does one assess a patient suspected of celiac disease? So there would be symptoms revealed by way of history taking, suggestive of malabsorption, such as diarrhea, steatorrhea, weight loss, unexplained acid reflux-like symptoms, dyspepsia, bloatedness, constipation, or diarrhea and fatigue. So these would be in the symptoms. Symptoms would also reveal any family history of celiac disease or risk factors for celiac disease, such as an autoimmune disorder, such as type 1 diabetes or thyroiditis. Clinical features of complications, such as anemia or features of malnutrition. There would be associated conditions such as thyroiditis or diabetes. So these things would come into discussion when history taking sort of leads to discovery of data. What does one do by way of examination and assessment? It is important to standardize weight gain or weight loss. So BMI needs to be calculated, and basic parameters such as general features of anemia, loss of weight, abrupt loss of weight, distension of the abdomen, poor musculature, and also features of anorexia. In addition, basic observed features of blood pressure, pulse, respiration, heart sounds, abdominal examination, noting of splenomegaly or ascites. Obviously, there could be features of anemia. And then, of course, one would need to look for any unusual skin features such as dermatitis herpetiformis. Arranging basic studies of full blood count, C-reactive protein, ferritin, vitamin B12 estimation, serum folate estimation, liver function tests, urea and electrolyte with EGFR, thyroid function tests, rheumatoid arthritis tests, fasting blood sugar, and serum amylase. If there are features of diarrhea and weight loss with abdominal pains, stool calprotectin needs to be done as well, so that inflammatory bowel disease could be confirmed or excluded. In order to do specific serological tests for the diagnosis of celiac disease, the patient should have been consuming normal food which would be containing gluten for at least 6 weeks before one undertakes the specific serological tests. If the patient has been avoiding gluten, the test becomes less reliable. So what one would need to do is to check the immunoglobulin A level, which is the total IgA level, tissue transglutaminase antibody level as well. If indicated, then subsequently immunoglobulin A endomysial antibody should also be done. But if IgA or TTGA is not available, or the results are controversial or weakly positive, then one would need to resort to checking IgG-mediated endomysial antibodies and IgG-related deamidated gliadin peptide. However, IgG-related tests are much less reliable than IgA tests. It is considered unnecessary at this stage to do HLA genetic tests in the primary care in respect of diagnosing celiac disease. If the symptoms suggestive of celiac disease persist, whilst the test is controversial or negative, then the tests need to be repeated after an interval of time. There are few possibilities with the serological tests. The TTGA tests is raised, IgA level is raised or normal, and endomysial antibody level is also increased. As long as one is assured that IgA is not deficient, then the TTGA tests are literally diagnostic of the condition, celiac disease. The other possibility is that the tests may not be strongly positive. And remembering that the diagnosis of celiac disease relies on a combination of clinical, that means symptoms, serological, and then endoscopy-related histopathological findings of the duodenal biopsy. That combination will lead to a definite diagnosis of celiac disease. Sometimes results are equivocal in terms of serological interpretation. Then one does alternative tests. So as I've already explained, that the TTGA level and the IgA level, if are not available, or if the findings are vague, then one needs to resort to IgG-related tests. In children at this stage, with vague, uncertain results, it is important to refer children to the pediatricians to consider biopsy of the intestinal mucosa. If the initial tests of TTGA, IgA, and EMA are negative, and one specifically checks for the IgA level, and if this is deficient, then the rest of the tests may be controversial or falsely positive. But if, on the other hand, the IgA is present in the normal quantity, then negative tests will exclude celiac disease. What would be the complications of celiac disease? Untreated, that means the gluten intake goes on, will lead to malnutrition and osteoporosis, iron deficiency, anemia, deficiencies of B12, folate, vitamin D, and in a pregnant woman, it would lead to low fetal birth weight and increased risk of lactose intolerance. Continuing challenge from gluten can be linked to small bowel lymphomas, not necessarily to adenocarcinomas, and may be linked to Hodgkin's disease developing in the future. But not enough data is present to be convincing that celiac disease is a precursor of such cancers. The differential diagnosis of celiac disease. To begin with, infective gastroenteritis, so symptoms, physical findings, parameters of lymphadenopathy or fever with stool examination to grow organisms, and CRP to confirm that there is an inflammatory condition going on. There could be non-celiac gluten sensitivity, and this is present when the serological tests do not indicate presence of celiac disease, and yet the intake of gluten has not been totally stopped. The differential diagnosis can also include fructose or lactose intolerance, such as in cow milk allergy or purely due to wheat allergy. In AIDS enteropathy, similar conditions occur. Diagnosis should be excluded of Crohn's disease because organs involved might be scattered with skipped lesions, or they may be localized large individual lesion with microscopic colitis seen on endoscopy and biopsy. Differential diagnosis also includes IBS, exocrine pancreatic disorders, diverticular disease, peptic ulcer disease, and of course, there would be suspicions in relation of seeing on imaging T-cell lymphomas or adenocarcinoma, and hematological parameters might show some features of hematological malignancy or hepatobiliary abnormalities. So if someone has celiac disease and has increased enzymes in the liver function tests, these could be associated to celiac disease, but also due to inherent hepatobiliary abnormalities as well. So the differential diagnosis must be made and hepatobiliary conditions excluded. So the management, according to the guidelines under the NHS, first of all, the starting point is that celiac disease is ill understood, even though linkage with gluten is well established, and accordingly, there is no cure for celiac disease. The advice to follow a gluten-free diet leads to controlling of symptoms and prevention of long-term complications, such as deficiency disorders, enteropathy, and so on. In diagnosed cases, there should be an annual review in the primary care with appropriate tests. If a person has been unsuccessful in totally avoiding gluten, then a referral to the dietitian might be needed. Significant information to patients can come from Coeliac UK, which is a charity, and the website is mentioned here with the helpline for them as well. In addition to local support group, and also advice sought from community pharmacists in what food items are safe. The Advisory Committee on Borderline Substances has approved of certain products which can be NHS prescribed. We'll mention of it in a little while. If there are persistent or recurrent symptoms despite alleged compliance, one needs to critically check, because sometimes gluten can sneak in as a contaminant. It may be present in the packaging or wrappers, such as in cereals, even though the content of the cereal will show that there is no gluten. So in addition to managing a person with gluten sensitivity and celiac disease, one should also check out for nutritional deficiencies, eating disorders, which may pre-exist or become a feature of complication when someone is diagnosed with celiac disease. In children and babies, faltering growth. In vulnerable adults, osteopenia. and in young people, depression and anxiety, and so on. Because of the potentials of vulnerability, patients with diagnosed celiac disease need to be offered protective seasonal vaccines, such as for influenza, meningococcal, and pneumococcal immunizations. In addition, if a person shows features of hyposplenism, then other protective measures, such as various kinds of penicillin orally as a prophylactic, should be considered. So, checking food items, which mainly the community pharmacist or dietitian does much better, one should encourage patients to contact the Coeliac UK to get details of various food items that patients should avoid and their substitutes, such as wheat flour should be changed to almond flour, savory flour to rice flour, flour wraps, as is common now in young people, to corn tortillas, breadcrumbs in various settings to gluten-free blended oats, wheat noodles changed to rice noodles, lasagna sheets changed to aubergine slices, spaghetti substituted with courgette, crackers changed to rice crackers, couscous changed to quinoa. Food items with gluten present will have the warning symbol like this. This is wheat. So what else can one do? One should advise on nutritionally balanced gluten-free diet. So just avoiding gluten, but maintaining all the other food principles that are necessary to maintain good health. Remembering that when food is labeled as gluten-free, legally it can still contain less than 20 parts per million of gluten. So it's not 100% free of gluten. There are some patients who react adversely to even very small quantities of gluten. Small quantities of gluten can be inadvertently introduced as a result of preservatives, wrappings, and packaging, which may contain small contamination with gluten, even though the contents of the food within is alleged to be no gluten containing. So patients should really read the label and make sure that they report symptoms quickly. Most beers have gluten from barley. Although oats, if they are pure, they are not gluten containing, but may cause problems. And some patients, roughly about 5% of patients with celiac disease, have problems consuming oats as well. Codex wheat is specially made reducing gluten to trace quantities, and these might be palatable and acceptable without evoking the gluten trigger related celiac disease symptoms. Corn rice, and potatoes can be eaten safely. It's amazing that in England, only bread and flour mixes are prescribed on the NHS freely. However, there are other products which can be prescribed by the approval from ACBS, Advisory Committee on Borderline Substances. And chemists can show patients, and the Coeliac UK will also have guidance on how to minimize costs. So we have gone through the celiac disease description, identifying it to be an immune-mediated multi-system disorder triggered by gluten or gliadin, mainly affecting small bowels with enteropathy of varying degrees of severity, and that this produces and evokes celiac-specific autoantibodies. And gluten is present in a large number of food items, which are, strictly speaking, difficult to avoid. And then, of course, there are oddities in respect of finding symptoms but no matching blood results, or blood results suggesting celiac disease with no symptoms. And also, with the best of efforts in avoiding gluten, if the person continues to have symptoms and the endoscopy and the histology suggests villus atrophy, then there could be refractory celiac disease, and additional features of celiac disease should be investigated. About 1% people in the UK have celiac disease, but of this, almost 10 to 15% only are positively diagnosed. And celiac disease occurs in two peaks, 6 months to 2 years, and between 20 to 30 years. The incidence is rising. And the etiological factors include a trigger from gliadin, could be genetic in siblings or first degree relatives, could be immunological by association with other autoimmune diseases such as diabetes type 1 and thyroid disease or Hashimoto's. It is generally associated with gluten. The symptoms are variable. The GI tract symptoms match up with symptoms of IBS or nutritional disorder, sometimes steatorrhea, or symptoms similar to reflux esophagitis. Deficiencies of iron, vitamin B12, and folic acid is usually detected incidentally on blood investigations. Anemia is a late consequence. Patients have vague symptoms such as tiredness. They have greater vulnerability. Serological tests basically show up with a very strong reliability. And the main one is to check the total IgA level in addition to tissue transglutaminase and antibody level. And if this is risen, and if IgA is normal or risen, the diagnosis of celiac disease is confirmed. However, the end diagnosis would be that with these positive results, one refers patients to the gastroenterologist who will undertake a duodenal endoscopy, and the biopsy would suggest villus atrophy. Sometimes there is a mismatch between symptoms and blood results, and we have already discussed how to proceed in such cases. Untreated or poor compliance with gluten avoidance will lead to numerous problems, and we have talked about it already. The differential diagnosis should be made from these conditions. The management will start off by explaining that there is no cure for celiac disease, and a gluten-free diet is needed to control symptoms and to prevent long-term complications. Annual review with tests are needed, referral to dietitian, signposting to Coeliac UK, and if need be, prescribing what one can based on ACBS approval, checking out for nutritional deficiencies, and offering additional protection with seasonal immunizations, and changing of eating pattern from gluten containing to non-gluten containing, and checking for labels for gluten presence. And of course, general health should be promoted. And it is possible that despite their manifest best results of avoiding gluten, a patient may still be exposed to gluten, which may be present as a contaminant in packaging and so on. So hopefully this presentation will have helped, and I hope that you are able to apply the revised knowledge into clinical practice. No one is an expert, but the real expert is the patient themselves. They know what food will provoke symptoms, what food would prevent such symptoms. And so they learn with experience, and they also have a good knowledge of what to seek, what to avoid, how to check food items given to them, and other patients who have already given their input and feedback to the Coeliac UK or such organizations will be the best teachers for patients to live comfortably whilst continuing with celiac disease. Thank you very much.